Hello, everybody, and welcome to Care Talk. My name is Laura Packard, and I'm your host. I am a patient advocate because about 5 years ago now, I was diagnosed with stage 4 cancer. And so I've had an upfront look at America's medical system. And I and my expert panelists are here to answer your healthcare and health insurance questions. And let's get started with our first question from Norma Jean, who wants to know when is somebody going to check in on long term care insurance? I've paid into it for 22 years and I just tried to get it because I have 2 chronic illnesses, but they would not allow me in home care. I was disqualified after jumping through many hoops for several months. And to answer that, welcome Diane Archer from Just Care and Social Security Works.
Thank you, Laura. And great question, Norma. We haven't touched on long-term care insurance, and we should have because long-term care, as we all know, is critical to so many older adults. I think it's 7 in 10 will need long-term care at some point in our lives. The issue is that long-term care insurance has increasingly become prohibitively expensive and not comprehensive in what it covers. And so fewer people are buying it, and for good reason. So let me just go through some of the issues. Every long-term care insurance policy is different, and many, if not most of them today, are probably not worth buying because their caps, the amount that they'll pay for coverage and when they'll pay for coverage, are so low. So that's why I'm not really surprised to hear that your insurer is not covering your in-home care. Also, qualifying for coverage is often really difficult. In many instances, you need to have to be unable to do 3 out of 5 activities of daily living, like bathing and toileting and dressing and eating or moving from a bed to a chair. So if you, Norma, only need help with bathing, for example, you wouldn't qualify. Other big concerns with long-term care insurance include the premiums that they charge. Often those premiums look really good when you're first buying the coverage and you're told that the premiums are level, but level doesn't mean that they stay the same. I don't even know if it has any real meaning other than to mislead, because premiums can go up, and tons of people end up paying in for long-term care insurance and then losing their coverage because they can no longer afford the premium before they even can use the coverage. In addition, I mean, a lot of these policies have inflation protection, but it's at most 5%. And sometimes the cost of care is going up way more than 5%. So the coverage you buy today may not even be adequate to meet even a small portion of your needs later on. So for these and other reasons, we advise that people really think carefully before buying long-term care insurance and maybe set aside some money to use for long-term care if possible down the road. That's not, I know, terribly helpful to you in this instance. So for you, Norma, I would recommend that you call your your state health insurance assistance program to see if they might help you look at your policy and see what you really are entitled to and see what it will take for you to get coverage. You might also talk to your doctor about what you would need to qualify for your coverage for long-term care, because maybe you're at the cusp of eligibility and just not quite there. And over time, you will get that in-home coverage.
Thank you, Diane. And our next question is for Zoid from Health Sherpa. Tell us about the deadlines for open enrollment for health insurance. If you don't have health insurance right now, what should you be doing, Zoid?
Yeah, so there are a few things. If you don't have health insurance right now, you may still be eligible to enroll through the marketplace. We're currently in the special enrollment period, which means that you do need to have a qualifying life event in order to enroll. So you can look these up on healthcare.gov, but there are such things as losing your insurance through your job, moving to a different state, so your insurance no longer applies in your new location. And then there's also a special enrollment period for folks who earn below 150% of the federal poverty line. And you can look up those numbers online as well, or just check for your eligibility on healthcare.gov or on our website on healthsherpa.com. And that is a monthly special enrollment period. So if you fall in that income level, you may qualify. Otherwise, if you don't qualify for the special enrollment period, open enrollment will start in November 1st. And it is not, I don't think it's confirmed yet, but we believe it is going to run until January 15th, just like it did last year. Though last year, you should know that in order to get a start date of January 1st, you still needed to enroll by December 15th. And so that is what we would expect for this year as well. But if you don't get in by that December 15th deadline, as long as you enroll by January 15th, you would get a February 1st start date. Again, this is kind of speculation. We haven't gotten the official confirmation yet, but that is what we are expecting for this year.
Great. And our next question is from Caroline, who is turning 65 next April. Right now, I collect SSDI. I got a notice in the mail about choosing my Social Security. Do I need to do anything, or will my benefits continue as they are? Diane.
Great question. So I did check this out, and it appears that your benefits should continue just as they are. You will transition from receiving Social Security disability income to receiving Social Security retirement benefits, and your benefits shouldn't change. You should get exactly the same amount as you've been getting. So that's the good news. I do still think that it's wise always to contact Social Security to confirm everything, to make sure they are going to do it the way it needs to be done, and also to make sure that you are signing up for Medicare. You should sign up for Medicare Part B. You'll get Medicare Part A automatically in the 3 months before you turn 65, so that your Medicare inpatient and outpatient care will be covered in full by Medicare as of your birthday month. And so 2 reasons to call Social Security: confirm that you're getting that transition from Social Security disability income to Social Security retirement benefits, and to make sure that Social Security is signing you up for Medicare effective on the first day of the month that you turn 65.
Great. And our next question, Zoid, I hear that Affordable Care Act health insurance policy costs may be going up quite a bit for next year. Can you tell us what's going on and what Congress is doing about it?
Yeah, for those who might need a refresher, when the American Rescue Plan Act was passed in early 2021, one of the many things it did was it increased subsidies for most income levels for Affordable Care Act plans. And it also got rid of that subsidy cliff. So previously, if you earned more than 400% of the federal poverty level, you were not eligible for any sort of subsidies. But with this, it capped what you would be expected to spend on your health insurance plan per month on the premium at 8.5% of your household income if you earned over 400% of the federal poverty line. However, the American Rescue Plan Act only set these subsidies to continue for 2 years, so they would expire at the end of this year. They would not apply for plans for plan year 2023. There is some talk that there is a bill going through Congress that could extend these subsidies. Congress tried previously in the year with Build Back Better, and that did not pass. So we are hopeful with this bill that it will pass. It's kind of a pared down version of Build Back Better. It would extend the subsidies for another couple years. And if that does not pass, unfortunately, there's a couple things that will happen. Subsidies will go back to where they were before. So everyone would get lower subsidies, which means higher premiums. That subsidy cliff would come back. And more likely than not, it's speculation, but based on what we're seeing, insurance companies will be raising prices overall in order to account for fewer people enrolling, which would mean that even if you don't get a subsidy, you would still end up having to pay more per month. So it would really negatively impact everyone. From what we can tell. So we are hopeful that that will pass. If it doesn't pass before August recess, there is still some hope. That something could get passed later in the year, but it wouldn't really impact this open enrollment period. There probably be having to be some sort of special enrollment period like there was after American Rescue Plan Act in order for everyone to take advantage of it.
Absolutely. Yeah. And from what I'm hearing, Congress wants to do something in the next few weeks before August recess. But the drop dead deadline for passing a budget reconciliation bill is the budget deadline, which is September 30th. So even if it doesn't happen in the next couple of weeks for whatever reason, they will have a little bit of time when they come back after August break in September to get it done. But that's really cutting it close because notices about your insurance premiums for next year will probably go out in October, if not sooner.
Mhm. Mhm.
Our next question is from Jim Smith, who wants to know, why do we need or why do we have for-profit insurance companies involved in healthcare? As a 74-year-old senior on Medicare, I'd like to know the rationale for the automatic payment of $126 that's taken out of my SSR every month. Diane.
Okay, so privatization in the healthcare system, at least in Medicare, is the result of a very successful lobbying effort persuading Congress, both Republicans and more importantly, Democrats, that private insurers could do a better job of delivering coverage to people with Medicare. Better quality care, they claimed, at lower cost. At that point, it was 10% less than traditional Medicare. What's turned out, as I believe you probably know, is quite the opposite. What we know for a fact is that the private insurers have cost the government and taxpayers about at least 4% more overall, which is billions and billions of dollars every year since their inception. And there's been lots of gaming, upcoding, and overbilling the government by literally hundreds of billions of dollars more. So it has not been at all money saving. And from a quality perspective, what we continue to hear from government agencies that oversee Medicare is that these private insurers, these corporate health insurers, have failed to provide them with complete and accurate information to even assess the quality of care they delivered. So what we say is no data, no value. They're not offering value. They're not offering quality. They're not offering money saving advantages over traditional Medicare. But politically, these insurers are incredibly influential. And as a result, there are very few members of Congress who are willing to take them on and to challenge the fact that they are really taking money from Medicare that we need in the Medicare Trust Fund to be spent on people's health care, to expand Medicare to cover vision, hearing, dental, and long-term care, which is what we desperately need. What it's going to take to get them out, or at the very least to stop overpaying them, is a big question. We fight and advocate for changes in the Medicare Advantage program as often as we can with as many members of Congress as we can. And we would urge you and all of our viewers to please contact your members of Congress and at the very least say that we shouldn't be wasting precious dollars, precious Medicare dollars on overpaying the private insurers that offer Medicare benefits.
Thank you, Diane. And for everybody listening, please keep calling and texting in your questions, and we will answer them in future episodes. So please, we want to hear from you, and we want to get you help. And now I'm pleased to introduce our special guest, Dr. Amy Macurdy Keatts, who practices in the Shenandoah Valley of Virginia and will be talking about patient safety and advocacy from a physician's perspective. So, welcome, Dr. Amy.
Hey, hi, Laura. Thank you for having me.
Great. So, my first question is, what should uterus having persons know about making sure they're insured?
So I liked what you all were talking about with access to healthcare through healthcare.gov. Most Americans get their insurance through their job since the onset of the Affordable Care Act, though you can enroll through the public option. The one thing that I would tell for all your viewers who have a uterus is contraception is very important, and it's now protected. So if you have insurance, even if it doesn't cover a lot of services, let's say for instance you have a high deductible plan, contraception, sterilization, those services are still typically covered at 100% with most policies.
Great. And I remember back before the ACA having insurance that did not cover contraception. And so it being an essential health benefit is helpful for millions of people out there.
Yes, it's been a great gain. We used to have to jump through all sorts of hoops to get a birth control pill covered, or progesterone releasing IUD. Those can oftentimes decrease menstrual bleeding. We used to have to jump through hoops. Now, if the person or the patient needs contraception, it's typically covered 100%. So big gain with the Affordable Care Act.
And what care should people be sure to receive every year, and how can they make sure that's covered by their medical provider?
So I'm a specialist in OBGYN, so I'm dealing primarily with women. Our recommendation for women is things like cervical cancer screening for infections, and then as women get older, screening for breast cancer, and then other general health screenings. Some of those are blood work. A lot of the screening tests that you would get, especially as you get older, are also covered by the Affordable Care Act protection. So, for example, a screening colonoscopy for an older adult, that should be covered 100% as long as it's screening.
And in these troubling times for reproductive health in particular, what are some other things that people might need to consider with their providers and insurance?
Gosh, it's for female patients, what I emphasize is just be sure that you have access to good birth control. We're hearing a lot of fear that the right to sterilization will be taken away. I don't specifically see that, but I do think that that's fear, and fear can sometimes drive people to do things. So access to contraception, and then thoughts about long-term what your values are and what's most important to you.
And Diane has a question for you.
Yeah, I wondered about Plan B, which is, as I understand it, contraception post-conception.
That's a great question. So Plan B unfortunately, it gets confused with the abortion pill. Plan B is not the abortion pill. It's basically a birth control pill that you take within about 3 days of unprotected intercourse, and that can prevent conception. I really like to talk to patients about that, because the abortion pill is a different process, and that's something that happens after pregnancy. Plan B can actually prevent conception, and so that's a wonderful option for people that become unexpectedly in a situation. Probably the most common is, someone's using a barrier protection like a condom, the condom breaks. Plan B is available over the counter in the pharmacies.
And is that also covered in full?
So Plan B, the coverage can vary. What I tell patients is check with your insurance. In most cases, I find most patients in the U.S. are paying out of pocket.
Okay, great.
And Dr. Amy, what should you be looking for when you're trying to find a good doctor? And what should you do if you feel like your doctor's not listening to you, not paying attention, or if you feel like you're not getting the care that you deserve?
So one of the things coronavirus has done is allowed you to access care by telemed now. So what I encourage my patients is find someone that you can work with preferentially in your area. But for a lot of the mental health needs, I think telemedicine is a good option. I think when a patient finds a provider that's not connecting with them, it's probably time to just move on to someone else. I like to say there's a doctor for every patient. I probably should modernize that to there's a provider for every patient, because a lot of healthcare today is provided by advanced practice, nurse practitioners, advanced practice physician assistants. And I definitely think that if you need access to primary care or other services, if you don't find the right person, move on and try someone else.
And there's all kinds of different providers. There's doctors and nurses and nurse practitioners and physician's assistants and all these different names. What's the difference, and what should you be looking for?
So I think ideally we'd all like to have a physician for all of our needs. The big issue with physicians is there's fewer of them as our baby boomer generation starts to retire. So physicians take a long time to train. They have the option to do surgical procedures, but a lot of physicians don't do procedures. So what I would view is a physician is needed if you need a surgical procedure or if you have something very serious like cancer or critical care. I think there's a lot of access points even into those specialties with nurse practitioners and physician assistants. The nurse practitioners and physician assistants typically specialize in one area and many times work as a part of a team, which would include a physician who may oversee multiple advanced practice providers.
Mm-hmm. Yeah, and when my oncologist was out on maternity leave, I saw the nurse practitioner in her practice.
And a lot of nurse practitioners are in Virginia, we've passed laws, they're in independent practice. That doesn't mean they don't work with physicians. It means that they can practice independently. They typically are part of a healthcare team, whether it's in a different practice or in the same building. Like probably with your oncologist, they probably work in a collaborative practice. So.
And with all the attacks going on right now on reproductive health, how comfortable should a patient be in talking to their doctor if they live in a state, especially where care may be criminalized? Should patients tell their doctors everything, or should they be careful not to put themselves or their doctor in a legal liability?
You know, I practice in a state that is not criminalizing talk about abortion at this time. I practice in Virginia. So I would say it's very state dependent. If you live in a state like Texas where criminalization of providers and possibly patients is an issue, I would be cautious with what you say. I think if you're in a state that doesn't have that problem, I think that you need to be open and honest with your healthcare provider. I think it's important. People need to know if you're dealing with something that involves abortion. It's an important part of healthcare.
And Diane has a question.
So I have a slightly unrelated question that's surfaced a few times lately, which is in this new telehealth world, I'm finding that folks are calling their doctors just with a quick question, do I need Paxlovid? I have COVID, or whatever it might be, and then getting charged hundreds of dollars for the phone call, something that never used to happen. Is that something you're aware of that's happening down in Virginia, or any thoughts you have on that?
Yeah, so I would definitely say that billing for telemed services is allowed and patients should be aware of that. When you reach out to your physician by telephone or if you arrange a video call, it is very possible they're billing an office visit. Now, is it widespread? I think most physicians and advanced practice providers aren't that sophisticated. And so if you're talking with your doc in a small practice on the weekend, you may not get a bill for that. If you're connecting through your primary care provider who works for CVS Minute Clinic, it is possible that they're billing. So.
And I guess they don't have to warn you about these bills because
Yeah, it's a good question. You know, when we schedule people for telemed, we probably don't treat it any differently than anything else. So from the patient perspective, I would say if you have an appointment and you're being scheduled, I would assume they're charging you. If it's a phone call that you didn't pre-schedule, I think that's different. I think that as a patient, it would be reasonable to say, hey, I didn't know that phone call on Saturday night generated a bill.
thank you.
Thanks. And I email my doctors occasionally. You know, I wanted to know whether I should get another COVID-19 booster before doing some traveling coming up. And so she replied pretty quickly. And I have never been billed for that, but it's a good thing to know that I maybe could be billed for emails with my doctor.
I've not heard of physicians or advanced practice providers billing for emails, but definitely for phone calls and telemeds. If you have a face-to-face with a clinician, I would expect that they're treating it as an office visit.
Okay, so if it's not urgent, it might be better to email your provider as opposed to trying to schedule telemed.
Yep.
Sounds right.
And what do you think about going to CVS Minute Clinic or urgent care or whatever versus seeing your doctor? Like, where's the line when you should wait and see your doctor versus just go to a clinic just to walk in?
It's a great question, and I may be an outlier compared to most American physicians. But you know, if you're traveling and you have access to an urgent care that is not your provider, I think it's better that you get care than you wait till you get home. If you're at home and you're able to wait to see your doctor, I think that's always ideal if you have a physician or an advanced practice provider that's able to see you.
And if you don't have a doctor, if you don't have your primary care physician, how do you find one?
You know, we have trouble where we live. We have a lot of primary care offices. They typically have very long waits. What I recommend, especially because a lot of my patients are healthy OB and GYN patients, I encourage them to get established with a primary care office so that when you do need them, like if you become sick or you end up in the hospital, get established so that you're already established. That way, when you call for your hospital follow-up, they know you.
It's a really important point. I just want to chime in here because I think there are a lot of people, especially younger people, who don't have primary care docs, and then they break their leg.
Right.
And without that primary care doc to refer you to a specialist, it's much, much harder to get that specialty visit.
Yeah. And I really think the primary care offices are just overwhelmed. They're busy. A lot of practices have seen a lot of change. In healthcare, everyone's changing jobs like the entire world is. And so getting established sometimes means you're established with an office. It is very possible your provider may leave, but if they have your chart and you can reach out to them, I think that's always ideal. Even if it means that you're seeing a nurse practitioner and you don't have contact with the physician. Primary care in and of itself can help coordinate some of the problems that will come up over the course of your years.
And sometimes when I've signed up for health insurance, I have been assigned a primary care physician. Like it'll say that on your insurance card. If you've just moved to a new location and you've just signed up for health insurance, they may assign you to somebody, which I guess means that person is taking new patients.
It should be. You know, interestingly, we've seen patients where they get assigned a primary care doc or provider, but they have trouble getting appointments. So I would always check that if you go to a new location and get one assigned, I would reach out to that office. Most offices won't consider you established until you've had a visit.
Yeah, so just to piggyback on that, I think that's a great idea. And I think if you're assigned a primary care doctor, even if you don't think you need to go, maybe schedule a visit because it will probably be 3 to 6 months before you get on the calendar. And then you have a chance to check out that doctor. You can switch doctors, obviously, if you'd like, but at least you have that appointment and you have a connection that you otherwise wouldn't have.
Most offices will consider you a new patient if they haven't seen you in 3 years. So what I recommend is check in with them at least once every 3 years, even if you don't need a lot. You want to maintain that relationship.
And your insurance should cover that. Annual checkup should be
Yes.
included
Yes,
in your insurance.
exactly. The annual wellness visit is on the top 10, the things that the Affordable Care Act protects. And so even if you have a high deductible plan, your annual wellness visit should be covered. And even if you only go once every 2 to 3 years, I think that's very valuable.
Absolutely. Well, thank you very much for being our guest. And thank you to our audience for listening and for asking your questions. So please keep calling and texting in your questions, and we will answer them in future episodes. Thanks for listening to Care Talk.